did his LBDS and MS Org from GSVM Medical College, Kanpur. Thereafter, he worked as a registrar in his parent department for 2 years, after which he set up his private practice in Kanpur. Dr. Prasad has received extensive training in joint replacement surgery across the globe. He has attended the prestigious Brighton course and extra course. He underwent training in computer navigation conducted by Royal College of Surgeons, Australia, and later with Professor Sharp of Heidelberg University, Germany. He worked with Professor Lawrence D. Dorr in USA and was trained in nuances of joint replacement techniques. He was also exposed to the evolution of the designs of joints. He also spent time in the developmental laboratory of implants in Tampa, USA, where a knee design was given shape. He is also an accredited AO Trauma National Faculty. He has presented guest lectures in various annual state chapters conferences and has delivered the prestigious B. Mukhopadhyay Oration in Bihar State Annual Meet. Dr. S. Prasad is an acclaimed philanthropist and actively involved in various social and charitable activities. He is the president of the Kanpur chapter of Ekal Vidyalaya Foundation, running schools and villages of India and Nepal. UPOA Orthopedic Association feels honored to present the prestigious Dr. Anil Gupta Memorial Commission to Dr. T.S. Prasad and UPOA 2022 on April 30, 2022 in Varanasi. Now I request Dr. S. Prasad sir to give his oration.
The association who have called me to give this prestigious oration. This oration is in the name of Dr. Anil Gupta, who was a young, promising orthopedic surgeon from Allahabad. Unfortunately, we lost him in very early age, and that too when he had already won the prestigious A.K. Gupta gold medal. So this oration is in the memory of a young orthopedic surgeon of our association from Allahabad. So with his memory in mind, we'll go and proceed for the lecture. So I'll be talking about my journey. So my journey starts very early, and it has got so many ups and downs, which I think many orthopedic surgeons in our setup, especially we call the Central India, can relate with. But I'm talking about joint, which I call surgery of the century, and this word is echoed by many across the globe now. This is a surgery which has changing lives of millions of people all over the world every year. In USA alone, 1.5 million joint replacements are done every year, and it is expected that in 2030 it will be 3.5 million. India, which has 4 times the population of USA, and now it is increasing in the infrastructure, increasing in the paying capacity, and increasing in health awareness. What we expect, the joint replacement scenario was not so good. In 1994, there were only 300 knee replacements were done. This is from a market survey of the joint which was sold across the India. In 2000, it jumped to 6,000. In 2010, it became 54,000, and it kept on rising. And now in 2019, there were 2 lakh knees and 80,000 hips. So what we expect, that it will be crossing around 1.5 million in the next 5 years. So you can see the graph, the way it's increasing. That shows we have got now more number of surgeons who are doing joint replacement, more number of patients who are willing to go for this beautiful surgery, which really changes their life. If it comes to my relationship and how my journey started, my first point will be a luck, chance or destiny. Don't be surprised, I'm a scientific person, you all are scientific people, but I'll just say, and if you look back, all the people who are seniors can look back and see how this small thing, which we may call small, very, very vital part in our life. Hard work for every orthopedic surgeon. This is something which is synonymous with all the orthopedic surgeons. Once you join orthopedics, hard work is bound with. Absolutely, you cannot separate two together. But the important thing was, and I was lucky again, networking with learning new surgical techniques. And why I was lucky? I was in the Department of Orthopedics of GSVM Medical College, and I was registrar. And luckily, the National Conference of 1984 happened when I was the registrar. The good thing was I was able to read a lot of performers, the lectures which were going to happen. I could pinpoint, well, this lecture looks interesting. So I made it a point to meet that faculty when they were there in the conference. So that was one. So that networking I developed. And still I remember I had a long talk with Dr. Mohandas. I was again lucky that I got my Professor Satyanand and Dr. Singer, who was my, I'll call not Dr. Satyanand, Professor Singer to my first mentor. I got a thesis which was in primary internal fixation in open fractures. And the first time in our department we did a thesis on AO principles and the plating. And that comes the point to have multiple mentors in the life. It started very early, you start with family, but you have to have, you can't have a single mentor. There are so many things to learn around in the life. So that again I'll say I was lucky to have so many mentors. We started with Dr. Singer, then Dr. Satyanand, and Dr. Singer gave me free hand to operate. I still remember when he gave me a segmental femur to nail my all other, and that I was a junior resident that time. All my other residents were so envious of me, and I had to throw a big party after that surgery. So that free hand gave me a lot of input how to go about surgical skill. Coming to life, this was a dictum which was told to me. You may think very high, you must have very big vision, but everything comes in small things. So making a small goals and achieve them is the way to go. The now management principle they call it divide and conquer. If you have to conquer big goals, first divide into, fractionate them, and then you conquer. And I have got so many other things to do in life, so that was a tough job. I have got so many hobbies, so sometimes I think my life is small and I cannot do justice. But yes, I followed all my passions were there, only prioritizing were different. But I'm a great avid lover of music. I play mandolin, I used to play violin. So one thing has happened, I left violin but I still play mandolin. Keen lover of sports, I still play every day almost excepting Sunday. I do read a lot beyond my orthopedics. I do travel a lot and do so many things others like social service. I'm involved, you will not believe I travel to villages and I'm in an association where I'm now regional president. I look after schools in the villages and deep connecting to the villages of Bundelkhand, and even for election, RSS takes my advice, what is the ground reality, how the things are happening. So being a doctor gives you a lot of privileges also, which you all have. Coming to the joints, what was my residency? Only this, excisional orthoplasty, the Gurdstone, and Austin Moore and Thompson. And you'll be surprised, in all my 3.5 years of residentship and registrarship, I only saw 3 Austin Moore being done in our department, and all the 3 got infected. But all the 3 worked very well compared to my other McMurray's osteotomy and excision orthoplasty. So that was one thing which can hit you in that young age. Okay, so that got infected, but still the patient were comfortably walking with a draining sinus all their own. And then I read about Charnley. You see, that was not the age of internet. Even the journals were not available. My library used to get JBJS where he used to fight. So yes, we got to know that Sir John Charnley has developed the low friction orthoplasty, which is a totally, and Dr. Dholakia in India is doing it in Bombay. That was my whole exposure when I finished my MS. But I was very keen, yes, this is the surgery of the future. And everyone in the department knew that. I did talk a lot about joint replacement, and Dr. Singer told me never answer this as a solution to any problem. He said you have to, in the case of TB hip or anything, you cannot answer a question as the solution of joint replacement, because then you will fail. The answer to any hip problem was arthrodesis or girdle stone, and that's it. But I was very keen, I have to learn this, and how I did? I got a lot of videos which was very prevalent those days by SKF and Boots, which had all these surgeries apart from joint replacement. I used to watch them. While looking at the acetabulum, I started doing osteoid replacement. I was trying to imagine how I'll be putting up my cup there. I was just imagining it, trying to find some avenues to learn it, and unfortunately I could not. Anyone whom I asked, they said, what you are doing? Kanpur, they used to laugh around. Joint replacement in Kanpur, in UP, that was a statement I got from 3 big surgeons from Bombay, and including Mohandas, and because I thought I'm very, he knows me, but he also refused. Nobody was willing to take me off for joint replacement. They all said you can learn and come and learn trauma. Again, luck. With the networking which I had made, I wanted to look for it, wanted to learn the trans-olecranon approach to elbow. I went to Delhi with a 2-year senior colleague, now he's a big consultant in Delhi. I'm not taking this consent, so I'm not naming. He sneaked me inside the operation theatre of a big consultant where he was going to perform a trans-olecranon osteotomy. I was watching the surgery, the surgeon could sense that he is someone else in mask cap also. He called me out, who are you? I said, I'm so and so. Who called you in? I said, Mr. So and so. So his registrar was taken to task, but luckily he had been examiner to Kanpur, so then he kept on asking, what do you want? I said, I want to learn joint replacement. He said, okay, come, I'll show you. So my first exposure to total hip was in Delhi by that famous surgeon who became mentor later on. He got me into IIL, he got me membership of IIL later on. He showed me the first hip where I was away. I could not see acetabulum, only I could see the cup going there, but the best thing was I could see how the cement was handled. I was watching cement on the video, but I never used to know what exactly. So the feel good was there. I could not see the acetabulum, but I could see the stem going well from across, and I could see how the cement was put. And that gave me enough confidence to go for my first total hip cemented. And this is the photo. I'm sorry about the photograph because that time there was no digital camera. This was the X-ray which was converted to a transparency later on, and I tried to take all this photograph from that transparency. So it's my first totally. I'm very happy because the patient walked. I did not allow my patient to walk for first 3 days. I was very scared, and then after 3 days I started exercises. After 5 days I allowed that lady to walk on a walker. But after that I was hooked. The way that lady who had not walked for 6 months after absorbed fracture neck femur, she walked and she lived for 22 years before she died. And then after, once that confidence was up to start going for total hips. And this is the hip where it was done in a young man, and closing that time it was a very highly criticized in my city also. You are doing a total hip in such a young man, but in the anti-business conduct, what you will do? Now we are doing, but at that stage, I was humiliated in all my orthopedic meetings. That is this criminal what you are doing. And this just, I am telling you how the time changes. So both the hips were done, one in the, I think, winters, and after 4 months I did, 3-4 months I did the other hip. That time the person was 23 years old. He completed his diploma in electronics. He's an engineer based in Gurgaon, drives a car, has his own house, and the right hip has 30 years follow-up and still going strong. I had to change the other one, and he came back to get the revision done by me. He showed to a lot of surgeons there also, and I did the left hip, and I was so surprised. The stem was tough to come. The cemented stem This is a friends, a simple I-notch Charnley stem. The socket was difficult to come out, the stem was difficult to come out. I could do a long stem, did a EQ also, so it was done in 2017. So the one way, this cheapest joint gave this young man his full life. He is now 55 or something and still lives, and this X-ray 2021 X-ray I got, he sent me on WhatsApp because I asked for his new X-ray. So he had done last year, so he sent it to me. But sometimes, as a young age, I became daring and I got overboard, and this is something I did which was available. That was all we had in our armamentarium. The two stems, the 40-45 offset, frankly friends, I did not know what does it mean. The only thing I used to do trial and see which one fits better, the 40 or 45, and used to do that cemented hip. And then the tumor, the lady unfortunately walked till the cancer took care of her life, but she was walking with support till she died. So how it started? So that was the initial years. I got a fellowship with Professor Rainer in Germany. And that's again a luck. I had gone to Calcutta to attend a workshop on joint placement and orthoscopy, where Rainer saw me using my both hands. I'm ambidextrous, and my professor always chided me for using my left hand. Once I was cutting the thread by my left hand, he hit me on my left hand. You don't have to use my left hand. And this fellow said, you are ambidextrous, why don't, your chief must have been promoting you. Well, no sir, he was always scolding me not to use my left hand. He called me to Germany, I got out of the turn, I got fellowship, went to Germany, and he became one of the mentors, which was a watershed movement in my life. He seeing my interest in scopy, he sent me to Dr. Strobel for a week, where for 5 days I stayed with Strobel to see how the ACL is done. He showed me the anterolateral approach and posterior approach for revisions. He changed my style. He showed me how to do a good cementing hip. He showed me how to do uncemented one. The most important thing, he showed me how to do a stepwise knee replacement, and that's all I learned. How to do knee without going more into concept. It was more a mechanical training for me, but somehow the hip training was better. And the two things I attribute very good. He told me not to touch the soft tissues. Soft tissues are sacrosanct. And his shallow was, why cut the poor muscle? Muscle will give you way. Why cut the poor muscle? And that was a very good thing. And that mentor, he got me my first AO fellowship. I had done my basic course in '93, so he got my AO fellowship. And he also got my wife a AO paid fellowship to the same institution where I was going, and that was one of its kind. This fellow was AO trustee, and one of his colleagues where I was again sent for training was Dr. Foringer. He was in Munich, he was also AO trustee. So both took fancy to me, and he really promoted to so many doctors after that. But he changed my life. He said, in Germany, you don't work only. You don't have to get all your patients to yourself. He had very judgmental views about Indian surgeons. He was a great friend of Mohandas. He said, I do not know why Indian doctors want all the patients to come to them. You cannot operate, you cannot treat so many patients. So you forget about number and look for the outcome. And that was the time I started collecting my records. When I came back, now I was wiser on those times, I started collecting my records, all the patient records. I tried to find how to keep it. Initially it was in paper form, later on it became in computerized form. These are the two stems I started using. And again, so I left my Charnley system behind and started using Muller stem, cemented. And this is a patient where the DHS done had failed miserably. And I did a uncemented CLS stem, which was my workhorse. Though it was costly, but I was trying to do it a lot. I was very comfortable. Cement was always messy, and this is a ceramic on ceramic, ceramic head with a ceramic liner that time. And I was also trained into using a metallic liner on the cup side, which was very popular in Germany that time. And this lady, also again after 25 years, this is the X-ray. So you see the original Charnley, which was the cheapest joint, had no cement disease, no poly debris, but this lady with a CLS system, with a ceramic head and ceramic cup, has got osteolysis. I'm supposed to revise, she was supposed to revise, but because of COVID, it has been delayed. This year I'll be revising her. So this is not the new ceramic, the first one. But yes, the ceramic can also produce osteolysis in such a great fashion. I also learned how to do Wagner and uncemented. So because I always found cement messy. And remember Dr. Jamal's lecture yesterday, he said cement does better, and this is one of the evidence that I am showing you. Yes, it does better. And the best thing, I started doing knee. And I can tell you friend, still if I go to do a hip, my heartbeat increases. But for knee, no. I'm never under stress. And I'll tell you what my complications also. So this is the first knee I started. This is not the first, it was I think my fourth knee, because all the three have dead. This lady is still living. The knee on the right is a bulky FS knee. I'm pretty sure many of you may not have seen this knee. I was trained into a cruciate sparing surgeon, and I was doing exactly stepwise what he had taught me. I didn't know, yes, these are the points, how to balance and how to create gap, that's all. It was a pure, no gap balancing, pure measured technique. The other knee I have done later on when I was doing cruciate sacrificing knee. And look at the cementing techniques in the both done by me, but so different. No cement in the bone in the first case, no stem cemented. Even the surface cement is very thin. That was I was taught that please cement should not go inside the bone. Look at the latter side. I was doing patella initially in every case as I was taught. Everything changed after 2000. And you look at the cement. I've done PFC sigma. The cement is there at the tip of the stem, and that in that case it is supposed to be the good thing. But when I started doing no cement should go inside the bone, this is what I was taught. And that joint is still doing so well after 25 years. Similarly, right knee, 21 years, but left knee is the Apollo knee. So that I started doing in 99-2000. Again, you see how it changes the life. So after 24 years, if you look at the lady, how she walks, a little bit surprised. She's a big lawyer, a little खाते पीते घर की महिला है, लेकिन she's doing her life so well. She's so indebted to me. She's full of gratitude. And just I took the video now. I called her. Can I take your video and show it? Because she's a lawyer. She said, okay, Dr. Prasad, most welcome. If I can be a role model for Spain. No, you are not going to be a role model for patients. You are going to be shown to doctors. And then again, 22-year follow-up and naturally. I started when the FS knee was withdrawn. I was exploring what to do. And I was doing Apollo knees, which was very similar to FS knee, but in smaller in size. And also tried the natural knee with the anatomical tibia plate and with the curved dish insert, which will take care of any cruciate insufficiency also. But I'm not happy. I did 4 of them, but they had less flexion. The flexion was not so great as it was in the other knees. So I opted out. I explored with the AMK. Ultimately, I started doing PFC sigma, and I was very happy with that. And I learned how to sacrifice cruciates, and it gave such a. My surgery became so fast. It made my life so easier to get a good outcome. And now, why should I try to keep PCA? I'll sacrifice the PCA. And I got another fellowship, which is again a changing concept. That was in 2005. I'll have to finish. I think I'll go little overboard. But that was with Larry George, and this was the first time I went into a conceptual training about the joint, and that was very, very important. And after that conceptual training, I got the opportunity to do executor and write intern course and various other fellowship. But Larry George told me what to do. These are the executor stem and C stem, which again I converted from Muller to them. And what is the need? How it has evolved? The duocondylar was the first one which were preserving both the anterior and cruciates. Then Freeman Swanson, which was again trying to preserve the cruciate. And then two distinct philosophies emerged. One was the functional route with the help of Mr. Walker, who was an engineer who changed the anatomical neck to a anatomical knee joint to a mechanical knee joint. And the other was anatomical approach where we were trying to preserve all the ligaments. The cruciate sparing are the one example, the LCS knee is one and one important, and the BCR knee, bicruciate retaining knee have come. So these are the examples of the anatomic group. And the functional group is what we have been using in the total condylar with the post and cam and the knee which you do or we do maximum. The patella has also evolved over the years after so many failures, 50% failure in 1980s to compare to 20% failures now. And the design of the femoral component has evolved also. We have got a physiological patellar groove or cylinder groove. So cylindrical groove is to catch the patella early, and the physiological groove is in the line of the natural patellar tracking. The mobile bearing skein, I did lot of RP and RPF also. Dual surface articulation, load sharing, but less wear, not proven now. So everywhere now we are saying fixed bearing works equally well. So why go further? The UKR skein, I was again trained with Professor Larry George by in elevator knee. He used to do freehand. And that's why I got to know the concept of UKR, how you are balancing a UKR. And I was doing alligator to start with, now I am doing the PFC partial. So this again, why I say I love my knee. My first UKR in 2001, my first one, doing a freehand. The jigs are not very helpful in this case. And it has worked so well, so many years, 21 years, and still doing strong. I have done the other knee, total knee. Again, Mr. Agrawal, bilateral UKR, done in 2002. 20 years follow-up, doing so well. No failures till date. But if you look at the number, I have not touched the 100. I am trying to touch the 100. I have not been able to touch the 100. Whereas my other joints, if I include hip and knee both, they have crossed 15,000. So the patient selection is very important for UKR. And you can be very beneficial, you can have very happy results. The metal, the resurfacing came, I was trained, lucky to get a first-time training and watch a live surgery of McBean. So, and also I was trained in the concept of how to choose the proper stem for uncemented. And I have chosen the coral because it fits our Indian anatomy better. But I've been using a couple of short stems also. I was trained into that. This is my first BHR. A son of a prominent doctor of Lucknow, physician's son, a software engineer, was in Chandigarh. I do not know why doctor agreed to get a BHR because that time only 3 people were doing BHR in India. I was starting, and the other 2 doctors, one was in Chennai, one was in Mumbai. Dr. Maria did BHR after me, so you can imagine. So this was my first BHR, and this is such a beautiful surgery. I played table tennis with my own patient 2 years later. And then the SR came, which are more user friendly. I started doing a lot of them. In fact, I was keeping my patient that yes, when ASR will come, I hope the video moves. Anyway, So it was an ankylosing case, nothing great, it will remove. The important thing is, 18 years, and this is doing so good. Look at how it has, the bone is incorporated there. And why it is so good? This young man, post-traumatic avian with vestibular fracture also. I did resurfacing, and you can see, I hope this video works. I like this video. This fellow is running, Shivam, no, sorry. So I will not avoid the video. Anyway, this allows the freedom to work and do all your sports. And there are people, I just received a patient, done bilateral knee, and she is dancing. Anyway, so this surgery was very good till it lasted. And ultimately, we all know the resurfacing have been partially withdrawn from the world. And I also went overboard. I did a resurfacing in a dysplasia also, which is never indicated. And I still remember the Luca Mariga told me, Dr. Prasad, it was an international presentation, I was showing me a series of ankylosing cases, and I also showed one of my dysplasia cases where I have done resurfacing. He said, Dr. Prasad, you have been lucky, God is with you, but God may not be with you in all the time. So please don't do in dysplasia further. So I took his advice also, that was serious advice. But I was doing a lot of short stem. I was trained into that. I started with Proxima, worked very well, and I was very happy with the large anatomical head which we were doing. So this was the journey I was evolving. And the things were changing worldwide. The development of new articulate couples, ceramic, and the cross-link poly has come. More insight into tribology and the shape of the acetabulum. ASR cup has already shown that it can fail only just because changing the shape of the cup. Large head gives you functional fitting. Now we know the 32 head and the 36 head are the both which can be used very well, and they have got better longevity. The bone conserving techniques have come and better soft tissue handling. So this will give you a high functional PHR. There is a silent stem, again a lot of, it's basically epiphyseal stem, you can say, going just into a metaphysics. But the failures are there. This is one of the stemmed M1 head which failed by this osteo. The gradual pain and suddenly the osteolysis where the stepped up augment, which was the only thing available. But I wanted to now learn more and more. I thought I was good, but my first knee failure shocked me. Because all the knee wear have been doing very well. So it became more learning and learning. I started computer navigation, bought my own setup, and started playing with the concept of the knee with the computer. And that gave me a lot of insight to how to play around and how to match my concept. Now I can do a freehand knee and get everything right on the scanogram. And there are so many things which have come of late. The kinematic concept, graduate curve I have tuned, which I am doing, the BCR design. But all are trying to get a better outcome. Now revision techniques have changed. This is how I do revision, whether I use a stem or not, but the sleeves are the thing to preserve, and they are doing very good functional results. Similarly, my revision hip has changed. I can use a cemented cup with a crossing poly cup. It works as good as any ceramic articulation. So things are changing. But what I want to say is, sometimes you can, all the concept and training can give you a lot of insight. Like this patient who had a gunshot injury in the childhood, and I could do with the sleeve a primary knee, and he start walking well. Young knee, but with so much of experience that the knee can last 25 years. I'll give him a good life. This is my aim. I'll not let him walk. And I've been doing, not in great number, the elbow replacement. This is a straight one, and the results are very good, and it's not a weight bearing joint, so again it works very well. And the reverse shoulder replacement in my hand has never given me good results. Luckily the reverse shoulder came, and this has given me very good results. Shoulder, I have burned my hand. I was never happy, my patients were never happy. At the end, friends, I'll just say, everything plays a part. The continuous learning is important, and the complications keep on happening. I'll just name four of them which have changed my insight and finish up. Number one, I perforated the femoral stem or the femur shaft by this stem. Luckily we have learned over the years to watch every joint placement in the image before the patient is shifted out. And that again, I had already watched out and my junior called, boss, ye to bahar pada hua. And then I went out. So that's one thing I'll say, the complication will keep on happening. Please, before you shift the patient out, check it out. The other thing, I have got lower threshold for open acetabulum, and once I have revised my own doing 2 days back, once I saw the X-ray post-op, it was looked good on this image, but the X-ray showed it is quite open. I insisted, and you can imagine how to convince your own patient who is walking also comfortably to go for revision surgery. I have broken proximal femur 4 times doing a short stem. So bailout procedures are a must when you are doing joint placement. I could go with when I perforated the femur, I could go and do it with a long stem. When I broke the proximal, split the proximal femur, I had to do another stem with a circular wire. That's very important. So this, and only once I have overlaid my posterior wall trying to accommodate a bigger head. And I burned my finger. I had to go to fix up a cage. So the backup should be absolutely essential in the joint placement. It is an elective surgery, friend. You have to visualize that things can go heavier. You have to have everything on the table that time. Luckily, in the knee, I have never had any per-operative complication excepting a fracture of a tibia, where I had to put up a small locking plate. Thank you, sir. Thanks a lot.
Thank you, sir, for the nice and elaborative journey to become a perfect and experienced orthoplastic surgeon. Not only the perfect osteoplastic surgeon, you are a perfect Mendelian pair too, and you are fond of cars too. Thank you, sir.